Good evening, everyone. Thank you so much for joining us today for our webinar on prostate cancer, covering the signs and the treatments. We'll be kicking things off with a presentation followed by an open Q&A session. Feel free to submit questions at any point of the presentation. You can do that by using the option at the bottom on your screen, and we'll answer those questions at the end. Our presenter today is Dr. Eric Giesler. He is a board certified urologist with Urology Austin. He's passionate about leading edge patient focused medicine and specializes in urologic oncology with a primary focus on prostate cancer. Dr. Giesler, we're so excited to have you today. Thank you so much for being here.
Thank
But
you. Thank you.
Thank you. But before we jump in, we just have a few quick announcements. Our Zero Prostate Cancer Run Walk is this Saturday in Austin, Texas at Concordia University. You can find out all the details on support.zerocancer.org, or you can just simply check out our posts on Instagram and Facebook. Also, we're super excited to share that Dr. Giesler will be on the Dr. Drew Show this Friday, tomorrow at 7 a.m. Central on the Lifetime Network. Dr. Giesler, I'll pass it over to you so you can tell us a little bit about the show and kick off your presentation.
Well, thank you, Sarah. It's Prostate Cancer Men's Health Awareness Month, so what a great time to sort of highlight the #1 cancer in men. And we were invited to come to Health Uncensored, Dr. Drew and one of my patients, to talk about one of the unique therapies we do here in Austin, Texas. And I just want to first start off thanking everyone for joining us tonight. I know your time is precious, and so I want to make this valuable to you. I know every listener is either dealing with prostate cancer or knows someone or cares for someone who is either having the diagnosis and figuring out what to do, or is through the initial stages and then maybe on to more advanced stages. And tonight, I really just want to be forthcoming. I want to really dedicate this to some very important people in my life. First, my father, a great physician and prostate cancer survivor. Gets me a little teary talking about him. And then my two grandfathers, both great men and prostate cancer survivors. And really my patients. You guys teach me every day. You and your loved ones are really just drive me to be a better doctor tomorrow than I am today. So I'll get over the emotion and we'll sort of get into the talk. And tonight, I really, again, want to make this about you. I want to keep this to about an hour. I want to try to keep it brief on my end for 30, 40 minutes, and then opening up to questions. And when I was in training, our chief had a fireside chat, and he'd ask us to ask any question we wanted. So that's what I ask you, and I'm going to do the best of my ability to answer that. And if we have more questions than time allows, we'll answer them in the future and just publish it in a video. But tonight, we're going to talk about localized prostate cancer. We're going to go from sort of risk factors, screening, diagnosis, and then some of the more modern treatments of that. We're not going to get into advanced prostate cancer. That's another talk for another day. And I could really spend a lot of time on each of these three issues I just talked about, but I'm going to go hopefully very high level and really pertinent points for you and your loved ones, and to hopefully get you the information you need. So I think today we get a lot of questions. There's a lot of confusion out there, not only about screening, what do we do for prostate cancer, what do we do for skin cancer, colon cancer, and people go like, why me? And I think that's sometimes the hard pill to swallow. Is like we go into our doctor, and the next thing we know, they tell us we have a cancer diagnosis, prostate cancer, and this. It's like, what did I do? And I think if we look at cancer in general, I usually think it's sort of three things. It's sort of this genetic predisposition and things that we can't control, our genes, our age, and then time, how long we're on this great earth. And then there are things that we can control. And those are things as our overall health, our weight, all our other comorbidities, maybe it's like diabetes or high blood pressure, or just stress. I mean, we all live in a crazy society. That 8-to-5 job never really works anymore. It seems like we're always online. We're always getting pinged. I just got 3 texts right before this started, and it just seems like the day never ends. And I think overall that all combines to give us a very stressful situation, even though we may not feel stress, but it's stress on our system that sometimes reduces our immune system and allows these cancers to maybe percolate a little earlier. And that's what we're seeing. We're seeing a shift in cancer earlier. Traditionally, when we look at cancer, we think, oh, it's as you age. But now we're seeing it in younger people, not only in prostate cancer, but breast cancer and colon cancer. And I was talking to my wife in preparation from this. And I was like, the youngest man I've ever treated for prostate cancer is 37. And the oldest man I've ever treated was 97. So it's a 60-year window that I've treated men, the most common age being in the mid 60s, 67, 66. But we're seeing it shift younger. And then we're also seeing cancer not only in 1 in 8 men, that being Caucasian, but often African and American men, it's 1 in 6. So we're seeing a much higher incidence in African American, and we're not sure why. There are some suggestions that maybe it's environment, maybe it's diet, but no one really knows. My personal opinion, there's a genetic predisposition to that. So when we think about cancer, you think about those things you can't mitigate. That's your age, your ethnicity, and time, and then the things you can, and that's environment, taking care of our bodies, and sometimes it's our jobs and where we work. Since there's definitely, we know firefighters exposed to toxic fumes. We know the 9/11 responders have had a great many cancers developed 20 years later. So we know that there's something in environment, we don't always know what, that's causing these cancers to percolate. And then we talk about screening. And I think this has been the most confusing. And so who should screen? Basically, every man should screen. Every man who owns a prostate should screen. But when do we start, Eric? That's the common question I get. And I think you really have to look at, are you a high risk individual or are you a normal risk individual? If you're like me, a high risk, like I said, my father, my 2 grandfathers, we have to start screening around 40. And what is screening? Screening is a blood test, a PSA, once a year, and they do recommend a prostate exam done by the physician in the office. Other high-risk individuals are African American race, and also people who have certain genetic mutations. Many people have heard about the BRCA gene. That's very highly associated with breast cancer. It's also associated with prostate cancer. Also, Lynch syndrome. Many patients have heard of this and may have it. You not only get genital urinary cancers, but you could get colon cancer, gallbladder cancer, and stomach cancer as well. So all those genetic, anyone who has a genetic risk, you want to shift that earlier. But if you're the everyman, it's really starting at 50. I've always said, guys, we sort of could muscle through for the first 50 years, and that's when our warranty expires. Not that we need to, that it's the end of the road, but that's why we need to take our bodies in a little more routinely, do a little more routine maintenance, because we just don't have the resilience we had at 45, at 40, at 30, and our bodies start feeling it. So really, when we talk about prostate cancer screening, it's really become this sort of what we call shared decision making. It's a partnership between the provider and the patient. And I think that's really where we've moved from a paternalistic doctor, hey, you do this, patient, to more of a discussion. Let's look at the whole person. Let's look at everything that person walks in with all their other comorbidities, and let's figure out what's the best pathway for that individual. Now, this next slide's a little busy, and you can screen that QR code, but this is by the American Urology Association. I like this because it gives us some broad guidelines as far as what do our levels really mean. Typically, a PSA, it's a value in the blood. It's a protein made only by prostate. And so it's elevated for not only prostate cancer. Sometimes a guy has a big prostate and they just make more PSA than the average guy. Other times you just genetically make more. When we make these tests, we put it on 1,000 people and we get this bell curve. And some people are just outside that bell curve. And an elevated PSA is not necessarily a bad thing. It's not something we have to treat. We just want to respect what it means. As long as it doesn't mean cancer, that's fine. We can watch it. And really, for men under the age of 50, we really look at a PSA of 2.5 as our sort of yellow flag. If you're 45 and have a PSA of 1, great. But if you're 45 and have a PSA of 2.75, that's sort of a yellow flag. That's sort of stop, blow the whistle, come see somebody like me, a urologist, and let's do some more testing. And then once we get up to 50 to 60, we sort of increase that to 3.5. If it's below that, we could check it maybe once a year and even every other year, as long as it remains pretty low. But once it gets above 3.5, that's again that yellow flag. And that's sort of when we want to see and do some secondary testing. And I think that's where a lot of miscommunication is, because a lot of people historically, oh, you have an elevated PSA, then you go right to a biopsy. And that's what people have really been scared about historically. And I really want to hopefully demystify that, and really that the PSA is now a more of a discussion point versus an action point. And these are some of our next level tests. And there's a bunch of them out there. And it really depends on where that person is. What is their rate of rise? Where is their OVAR number? There's some other blood tests that we can do, such as a 4K score and a free PSA. These are all tests based on PSA. But if you're one of those guys that the PSA doesn't really track for you, you make more than the average person, maybe we want to do a non-PSA test. There's some urine-based tests looking at certain proteins, telling us, hey, is that person at an increased risk or a decreased risk? And then if we do get a little more nervous, we could do some better evaluation of the prostate. There's some better ultrasounds, but really the gold standard to evaluate the prostate is a multiparametric MRI. And a lot of my patients come in, hey, can we do an MRI? I said, great, let's do it, since it really gives us a lot of data. It tells us, one, what's the architecture of that prostate? How big is it? Is there anything concerning inside of it? Or if it's normal, great, that serves as a baseline for future use in case that PSA goes even higher in 3 or 7 years. But ultimately, the only way to diagnose any cancer is really to get tissue. And so the MRI, all these other tests do not replace getting tissue. And that's the prostate biopsy. And the prostate biopsy is done in the office. And historically, it has been a random biopsy. We've sort of taken 6 to 12 samples, right and left, hope we hit, a good portion of that prostate. But really, we were really concerned about, did we miss something? And that's really what has driven that fear of missing something, that really has historically driven the over-treatment of prostate cancer historically. And that was the big argument back in 2012 when they came out, hey, maybe we shouldn't even screen for prostate cancer, because really it doesn't kill that many people and we're over-treating and we're causing harm. And I think, there was some truth to that. But it does kill patients and it can get aggressive. And just because you diagnose it doesn't always mean you need to treat it. And so now with the MRIs, we could do a much more specific biopsy. And when I think about a standard biopsy, 6 or 12 random cores, that's sort of as good as it's going to get. Hey, there's some cancer there, but we know if we were able to remove that whole prostate, look at it under a microscope, we know about 40% of those men will actually have more cancer than that standard biopsy will have. And so a lot of times we underdiagnose in that situation. Now with the MRI guided biopsy, this is where we are able to take the ultrasound in real time with the MRI, fuse it to make this model where you see this green blob sort of in the middle. That's the area of concern. You can see below that, those are sort of your standard biopsies. In this situation, and I'll show you some real life ones in a second, we would have missed that tumor because it's in a spot that's sometimes hard to get. But with the fusion biopsy, you could see those two tumors went right through it. And unfortunately, this patient was found to have prostate cancer. But when we look at this, we know we're getting a better biopsy. So we're getting a more specific diagnosis. And that's the key, getting a very specific diagnosis. And that will help us figure out what is the risk to that patient. So if you think about that standard biopsy, that's as good as it gets. The fusion biopsy is like, that's as bad as it could get. We know data shows after a fusion biopsy, if we were to able to remove that whole prostate and look at it, less than 5% of those people actually get upgraded as far as score. And so when we look at the pathology, we give it something called a Gleason score. And these are actually two patients I saw on Tuesday. They happen to be in my office. And this is a perfect example why precision matters. And we've been doing this here at Urology Austin since 2018. We felt this was important to purchase the machine and really have been doing it ever since. And the majority of our biopsies, when indicated, are done with the fusion technology. So in this gentleman is has a family history of prostate cancer. He's actually a physician, and his PSA had just jumped a little bit. It was still within a normal range, but it jumped a little over a point in a year. And again, that rate of rise, that velocity of change, is a little concerning. And because of his family history, we elected to get an MRI. And the MRI showed a 5 millimeter lesion. Not very awful, but we elected to do a biopsy. And you could see these first 12 areas, all green. That's the standard. That's sort of the base. And those were all negative. And had we only done that, where we said, hey, look, there's no cancer, we're good. And then what could have happened is the cancer that we actually did find could have percolated for some years, and then it could have been worse. But now we've caught it very early. This is something we call a Gleason 6. So when we look at prostate cancer, we sort of take it out, we freeze it, we look at it at a microscope, and we give it something called a Gleason score. And the Gleason score is a score 6 through 10. Historically, there was 1, 2, 3, 4, 5, but really it's 6 through 10. Gleason 6, this is what we call low-grade cancer. This is the cancer you hear about that we can monitor. There's actually a debate out there. Should we even call this cancer? Because it has such a slow mutation rate. And really, should we stress people out with this diagnosis? And I say, call a spade, but just because we find it, again, doesn't mean we need to treat it. Then there's Gleason 7. There's two ways to do 7, 3 plus 4 and 4 plus 3. And this is what we call intermediate grade. This is actually the most common grade we see. And this is what we just found in this patient. This gentleman was a patient who actually has a genetic predisposition to colon cancer, which he was diagnosed in his mid-40s. He's now in his mid-60s, colon cancer free, but his PSA had spiked just above 4, just above that record. And then we did an MRI, and it did show this area. It actually showed 2. And had we just done the standard biopsy, which we did, no cancer found. But one of those 2 areas did have what we call intermediate grade cancer, a 3 plus 4. And so that takes it from, hey, there's no cancer, to, man, we've caught this early, but now this is the type of cancer we really want to treat. But the good news in this situation is he has a lot of great options to treat this cancer. And so now it's a discussion of what's the best option for him. And I'll get into that. And then we go on to Gleason 8, 9, and 10. These are high-grade cancers. These are the cancers typically we need to be a little more aggressive to. And so those are much different discussions in that setting. But we've gone much farther than the pathology. I always tell people the Gleason score, that's just a moment in time. We look at this cancer, we freeze it, and it's sort of like a Christmas card. Everyone's sort of smiling, or maybe they're not smiling. And then really, what's this cancer going to do in the future? And so we could send this pathology to look for certain genetic signatures. There's several different tests out there, and it sort of gives us a future cast of what this cancer's going to do. And we run these tests depending on the patient, depending on the grade. But again, this is sort of next level risk assessment to really figure out how aggressive we need to be with this person to really get the highest cure rate and hopefully minimize any collateral damage or negative side effects to this patient. So really, I want to spend a majority of this talk on treatment options. And this is sort of the art of prostate cancer. I love AI. I think it's going to really change how we live as a society. But in this space, I'm not sure if it will take place of the discussion patients and I have in the office with their loved ones to really figure out what's the best choice for them, because everyone comes in with different fears, different things that are important to them. And so that's sort of what we need to figure out together as a team. And so when we look at prostate cancer treatment, in my brain, it's always been a all, none, or some. And sort of traditionally, it's all or none. We either remove the whole prostate, even though we have a little cancer there, or we monitor it. We don't do anything. And the traditional treatments to treat the whole prostate are robotic prostatectomy. That's what I do quite a few of every year. And this is removing the whole prostate. And that really has the best long-term cure rate, but it also has some significant side effects. And I'll come back to that. Then radiation. Radiation is a great treatment for some individuals. And this is a treatment for the whole prostate. And then none, that is sort of monitoring the cancer with the intent to treat. You'll see 2 different terms out there: active surveillance and watchful waiting. And then there's some. This is really what's come about in the last decade, ever since MRIs have come and infusion biopsies. And so now we don't have that fear of, hey, are we missing cancer? Did we miss something? on that biopsy. And so now we say, hey, Eric, if you only have cancer right here, can't we just treat here, leave the rest of the prostate alone? And that would maybe mitigate the risk I have for urinary side effects or sexual side effects. So that is a discussion in some people that we can have in certain instances. So active surveillance and watchful waiting, these are two different terms, and sometimes people mix them up. But active surveillance is really the main one we use. This is monitoring the cancer with the intent to treat. And I know when we talk about this and I talk with a patient, this is not something you could just flip a switch on and say, hey, I'm good. I'm just going to watch this cancer. It causes a lot of anxiety to a lot of patients. And I know that a lot of times I'm on this side of that conversation, and as I tell many patients, I don't wake up with it. I don't sleep with it. And I think it takes a process to really come around to feeling like you're in control. Because I think when we hear that C word, that cancer word, it's a mortality check. Let's be honest, it is. Hey, am I going to see my son or daughter get married? Am I going to see my grandkids get out of elementary school? What are those things? And I think in this scenario, a lot of times we get to flip that paradigm. Instead of the cancer dictating what we do, we get to dictate what happens to the cancer. We take a very offensive approach. But that is something that takes some time. And some people can't wrap their head around that. And it's very stressful. And sometimes we do need to treat those cancers for that patient because we know that the psychological impact and stress from having the cancer diagnosis is sometimes worse than the cancer. And we need to address that. And then watchful waiting, this is where we're not really going to treat the cancer, but maybe we're going to just make sure it doesn't cause any negative side effects with patients. And that is maybe patients who have other comorbidities that, are more pressing, such as heart disease or have movement disorders or neurologic disorders. Now we're going to talk about your traditional treatments, and this has really come a long way. Now, the robotic prostatectomy is the preferred way of removing the prostate around the world. 90+% of prostates are removed this way. It's no longer something new. It's really become the standard of care. And this surgery really came about when I was in training. I remember the first one I saw was 12 and a half hours. It converted to open. When I graduated training, we were down to about 4 hours. Now this surgery is about an hour to 2 hours. It is outpatient surgery for a majority of people. They go home the same day. You do need a catheter. This is a tube that drains your urine, and that's typically in there anywhere from 4 to 7 days. Sometimes it needs to be a little longer depending on the surgery. But the risk of this surgery is what everyone fears, and that's really two: urinary leakage and then sexual dysfunction, being able to maintain an erection. The urinary leakage, these days, we can really predict who is going to leak. A lot of times we can tell that just by the MRI. We have a very good anatomy. And I always tell people, you never go into surgery blind anymore. You have this great GPS. So we know what we're getting into. We know where we have to go a little wide. We know that, hey, maybe that person has some anatomy that will predispose them to leaking. And maybe surgery is not in their best interest because maybe the radiation is just as good as curing that cancer, but doesn't carry that risk of urinary leakage for this individual. And then sexually, the nerves to the prostate or to the penis run around the outside of the prostate, and those are the things we gently dissect. Sometimes the cancer involves those nerves and we have to take some of them, so that does leave that person with some permanent sexual dysfunction. And let me define sexual dysfunction. I always tell, like, I have to wear readers now. I don't have them on right now, but I have to wear them, and that's how I look at sort of erectile dysfunction. You need something to help you do a little better. Impotence, that's where the penis does not work, is no function at all. That's sort of like blindness. There's no glass thick enough to help me see. And that is very low risk these days with surgery, but it's still there. Radiation, I think this is probably the most confusing thing to read about online. I think it's an alphabet soup. You'll see all those letters and numbers down there. But at the end of the day, radiation is to treat the entire prostate, whether it's external, where it goes from the outside to the inside, or we do radioactive siege, which really isn't done as much anymore due to the advances in external radiation. But we have all our patients diagnosed with prostate cancer who we feel need treatment, meet with a radiation oncologist. We are fortunate to have two great radiation oncologists work with us here at Urology Austin. And I always tell people they're not salesmen. They're very passionate about what they're treating, and they're very good. And details matter when it comes to radiation. And I could talk from experience that we have two great ones who work with us. And I really want everyone who has this diagnosis, if they don't meet with a radiation oncologist, if they come to me and say, Eric, I want to have surgery. I said, have you met with a radiation oncologist? They say, no. Well, you go meet with them, then come tell me you want to have surgery, because you really can't make an informed decision unless you know about all the treatment options. And then in some individuals, as I was suggesting, that we could do some more targeted therapy. And in our practice here in Austin, I would say about 10% of the people we diagnose are eligible for this. Because if you think about the prostate like your face, millions of glands balled up together, you can get cancer in any of those glands, just like your face. And a lot of times, prostate cancer is multifocal. It's sort of raindrops throughout the prostate. It's not just one little tumor that sort of grows from there. But in some individuals, it is. It's localized to an area of the prostate. And we can treat it with many different modalities, and they're all very good. It just depends on what, where that tumor is, what's the architecture of the prostate, and we really want to pick the best tool for that individual, and hopefully get the highest cure rate with minimizing the damage from the treatment. And this is sort of theoretically what we look at. And if you look in that far left, that's sort of that whole gland. You could say that's like radiation, even though you have that speckled red cancer on the right and left. We'd want to treat the whole cancer, since we want to get some area around that cancer to make sure we're not missing, as one of my patients so wisely said, sleeper cells. Just because we can't see them on an MRI does not mean they're there. Then we have other gentlemen who just maybe have cancer on their right side or left side, but it's a little more. So we might have to treat all of that cancer. But because of that, we could really miss a majority of the nerves, and that really mitigates any kind of sexual function or dysfunction for those individuals. And sometimes it's really small. We catch it super early, and then we could be really precise and really minimize that. But if we go down that route to this focal route, you have to be willing to monitor this cancer. I think about it and correlate it to breast cancer, and I hate to try to compare those two terms, but about 70% of women who have breast cancer have a lumpectomy. But those women know that they're on surveillance for the rest of their life, getting mammographies, MRIs. They may need biopsies, and they may need additional treatment. And so here, these gentlemen who opt to do focal therapy, they're not done. They need continued PSA. They may need MRIs. They may need biopsies, and they may need treatment of that cancer that develops somewhere else in their prostate. And so I think when you think about what is the best treatment option for that individual, it's really a risk assessment, or what am I worried about? Some men, they just don't want want the cancer out of them. Just get it out. And so those guys are going to select more towards whole gland treatment, usually surgery. Other guys hated the MRIs, didn't like the biopsies, but they would be devastated if they leak urine. Maybe they're a public figure, such as a minister or a school teacher. And so those gentlemen may go towards radiation if it's appropriate. Other guys would be devastated if they leak or if they have any kind of sexual dysfunction. And so those guys are going to really look towards the more precise treatment, but they know they may need to have additional biopsies and treatment in the future. So they have to accept that. If they're not willing to accept that, the targeted therapy is not really for them. And so that's where I think every individual has different, risk aversions, and it's different for everybody. And our job is to sit down together in the clinic and really figure out what's the best thing for that patient, what's going to get them the best cure rate for their cancer, what's going to hopefully mitigate any side effects that are important to them, and what's going to help them have a long and prosperous life from a cancer perspective. And so also there's a lot of new things on the horizon. And being at Urology Austin, I'm blessed to have a great research department, and Dr. Mazzarella, our director. And, I've been an investigator on 3 great studies in the last year. 2 of them are current. One we just closed. These are national and international trials The vapor trial was one we actually recruited the most in the country. It is now closed, but it really was looking at a new technology to focally treat cancer. Another one that we're participating that I'm really excited about is Water 4. This is a study that looking at a different way of treating the whole prostate using water ablation to remove the whole prostate. It's really novel and it's really exciting. And then finally, a great company has come up with this scaffolding that we could place after we remove the prostate to really mitigate urinary leakage after surgery. And we're blessed to be a part of that trial. And we're seeing some really exciting things coming on in the next few months. So that's what's also great about being in a great group. Not only do I have a great group of colleagues and partners, we're able to offer our patients things that they can't necessarily get elsewhere in Central Texas and even in Texas. So that's exciting time. And when it comes to me as a physician who really specializes in prostate cancer, from the diagnosis to the treatment to the advanced treatments for our patients, it's really a very neat time. We have so many new technologies. We're getting so much better at figuring out the risk for that individual and understanding that cancer better. I think historically we've underestimated prostate cancer. Said, oh, we'll just do this one treatment. But we know 30 to 40% of those people would need additional treatments. And so we've sort of underestimated, and now we're getting a much better understanding. We have better imaging. I didn't even talk about PET CT scans, which we do in our high-grade cancers. And so we're seeing things that we've never seen before. And it's, again, allowing us to really help those patients get the best treatment, because truly the first treatment, your first shot at treating that cancer is your first shot. And so you want to come out really strong. And sometimes we do have to be aggressive, but sometimes we don't. And we can mitigate side effects. So for me, that's the exciting time. And it's something I look forward to participating in for hopefully many more years. And so with that, I just sort of want to, lead off like, what do we do as men? And frankly, as people, as humans, I think we've sort of said, oh, we'll let the doctor worry about that. But I think now with internet and TikTok and everything else, we need to be a little more accountable to ourselves and be honest with ourselves. And as I said, man, we could sort of, make it to 50, then that's 50-year warranty expires. So, I always say, hey, you should know your body, pay attention to it. If things don't feel right, don't, seem right to you, go see somebody, whether it's a family practitioner or a PA or nurse practitioner. Just go get somebody to give you an opinion and then do some testing. And also, you should know your numbers. And you should know what your blood pressure is. I go to HEB and they used to have a blood pressure cuff, but if you don't have one, I would encourage you to buy one. They're 20 bucks. But know what your blood pressure is. You should check it a few times a year and just know what it is. If it's normal, great. Also, you should know your cholesterol. You should know your blood sugar. Since as we age, we sag, we lose elasticity. So our blood vessels do stiffen. So we get more apt to get higher blood pressure, and then cholesterol. With that, you can get calcifications in the heart and other parts of your body. So you worry about stroke. And then finally, for men's health, we worry about PSA. Again, every man should start at 50. If you're a high risk like myself, you want to start in your 40s. And then your testosterone. This is not generally checked for well men. And I think it's very important as an aging man. I definitely have been doing this now. I've seen these great men in their 60s, now in their early 80s, still in great shape, but I've seen what happens to bodies as they age, and I've learned to appreciate monitoring these things. And then finally, like I said, if things don't feel right or look right or your numbers are out of whack, you should schedule an appointment to see a provider, whether it's us with Urology Austin or anyone you trust. I encourage you not to give up and be an ostrich and put your head in the sand. And with that, I really want to stop and open it to questions. We're sort of coming on that 30-minute mark. Here's another shameless plug: primetime viewing tomorrow. Whatever morning show you watch, you can watch it on that. And really, the Zero Prostate Cancer Run here in Austin, they have them all over the country. It's really a fun celebration every year. I didn't think I was going to be able to make it this year, but I am, so I'm very looking forward to that this weekend. And with that, I'll open it to questions.
Awesome. Thank you so much, Dr. Giesler. The first question that we have is about the best diet to be on and also the worst items to eat for prevention and also when you do have cancer.
Well, I think when you look holistically at diets, and number one diet that sort of always comes to the top is the Mediterranean diet. That's high fruits and vegetables, low red meats, fish, high omegas, and that's really when you look at globally at diets. If you want to look at what I would say, what's a cancer protective diet, I really say what's a cardioprotective diet. And as I said, the cancer is sort of genetic predisposition, time, and then environment. Not only environment, but it's the inflammation. And it's not only what surrounds us, what we inhale, but it's also what we eat. So we know pro-inflammatory diets such as, barbecue beef, which I love, but you got to be in moderation. Um, High fatty foods, anything that comes in a wrapper, probably not the best thing for your body. But I know that's hard to do. I can't even do it. But if you really wanted to get strict, I think a Mediterranean and pure plant-based diet is probably the best for not only preventing cancer, but also if one has cancer, can help that body maybe fight it off a little more. But there's a lot of good people a lot smarter than I am on the health food front. But I think, if it's a heart healthy, generally it's cancer healthy. And we also need to remember what is the most common killer of Americans? Heart disease and stroke, then cancer. So we really don't want to lose sight of really what gets us more often. So if you follow your heart, usually the rest of the body will follow.
Okay, thank you. The next question we have is, it says, my primary care physician informed me that a physical prostate exam is ineffective and no longer recommended. Hence, the only screening I get is the PSA reading. Is this correct?
It is not correct, but the American Academy of Family Physicians do not feel that the rectal exam is appropriate. I will tell you that about 25% of the men who have normal prostate PSAs have abnormal prostate exams. That is actually how I found some of the most aggressive cancers in my career. These gentlemen had normal PSAs, but their prostate was severely abnormal. So it is still recommended. And this again is where I think you have to be an advocate for yourself because I hear this time and time again. My primary doctor stopped checking my prostate, 10 years ago, 5 years ago. So they do the PSA, but they're not doing the exam. Advocate, ask them to do the exam. And it should be at least once every other year. And if it is normal, great. It takes about less than 30 seconds, but I would advocate to have it.
Okay, thank you. The next question is, what is the risk taking a prostate screening test?
I think historically the risk is, oh, that screening test is abnormal. Now we're going to go do a biopsy. And that's frankly what we did 20, 30 years ago. You got to remember the PSA is actually not a very old test. It was really developed and approved by the FDA in 1986 and wasn't used to screening until 1994. So it's really in the spectrum of tests, it's pretty young. But back then we didn't have a lot of things. So if we had that PSA that elevated, we went right to biopsy. And the biopsy, although low risk, does have some risk. But I think now just getting that screening test, you're not going to go right to a biopsy, or you should not go right to a biopsy. There's several other next level tests that will give us a lot more concern or lack of or reassurance that there's no cancer and hopefully forgo biopsies. And if you look historically at just the biopsy positivity rate, when you go to the early 2000s, the biopsy positivity rate was about 20 to 30%. So that means about 7 out of 10 people did not need a biopsy. Now, with MRIs and second level testing, the biopsy positivity rate in our practice is north of 70%. So that's only 3 men who don't need a biopsy. But a lot of times, those 3 people have some abnormalities that we find, not necessarily cancer, but so abnormality. So I don't think there's any harm in starting a discussion. And that's how I look at the PSA. It's just the start of a discussion. And so there is no harm in that.
Okay, thank you. Next question is, what do you know about the new MRI assisted biopsy where the patient is actually in the tube during the procedure?
So those have been done for a long time. And in my career, I've had to have two patients have those done because we were unable to access that area through traditional means, and we needed to do it. The issue with when you do that biopsy, generally you're only doing a few samples of a certain area. And so you're not really getting a full biopsy. And really, when you look at what we call in bore, that's being done in the MRI machine versus fusion, which we can do in the office, there's not much statistical difference in detection rates, except in certain areas when guys have very large prostates that we just can't get to. So there is some value, but I would say it's probably not what we'd want to do as for everybody, frankly, because I think it will miss a lot of these what I call those sleeper cells, the ones we can't see on MRI. And so that's what they can't get on the inbore, but they are very good for certain situations.
Okay. This one says, my husband has a pacemaker and can't get in for an MRI till 10:30. His PSA and ISO PSA has risen each of the 3 times tested from July to September. Is this wise to not biopsy sooner? We're concerned by this delay.
Right, and I definitely understand that concern. And I'm not sure what his PSA level is. I'm assuming they're doing the ISO PSA. It's probably a single digit number, such as 5, 6, or 7, probably not 20. So when you look at, let's just play and I'm assuming his rectal exam is normal, because if it's abnormal, they could probably forego an MRI to do the biopsy. So in that situation with a normal exam and a PSA that's single digits, worst case scenario, if there's aggressive cancer there, it's not spread. And we know if we treated it today or we treat it 6 months from now. So worst case scenario, we treat it today, 6 months from now, there's no statistical difference in outcome. So I know that psychological emergency and urgency, we want to get this done. But unfortunately, we are dealing with a system that is taxed. We just don't have enough radiologists. We don't have enough MRI time. I know I had my MRI recently on a Friday night at 8 o'clock. So everybody, I think, is this wait is definitely here in Austin. Difficult for some people, but I think just to reassure you, assuming those two things I said, I think it's safe. That's a very safe time frame to wait to get that MRI.
This question is asking to please explain the use of PET scan for level of cancer.
Yeah, the PET scan has really been the game changer, and this is a PET PSMA, prostate specific membrane antigen, getting real technical here. This has really been the game changer, and we really use this with patients who are what we call a high intermediate risk. So that's a PSA of double digits with a Gleason 4+3 or any Gleason 8, 9, or 10. So if you have a Gleason 4+3 or 8, 9, or 10 or a high PSA, that's when we get the PET PMSA scan. And really what that scan is looking at is not the prostate per se. It does look at it, but we're worried about disease outside the prostate, what we call micrometastasis, things that we can't see on traditional imaging, such as a CT scan or a bone scan, which we have historically used.
Okay. This question says, does an enlarged prostate without any symptoms a matter of particular concern, especially with a slightly elevated PSA?
Well, again, that's where knowing how big it is, whether it be with a ultrasound, you can get size, or through an MRI, you can do what we call PSA density, and that is where we take that PSA and divide it by the size of your prostate. So let's say your prostate, a normal prostate is 30 to 40 grams. Let's just say yours was about 50 grams, which is the size of a tennis ball. And let's just say your PSA was around 5. So 5 divided by 50 is 0.1. So anything below 0.15 in a Caucasian male is a low risk for prostate cancer. In the African American, we drop that down to about 0.11, 0.12. but that PSA density, really does help. So I have a gentleman, I've actually treated his brother, and I have not had to treat him, but they have these massive prostates in their family. They're 300 grams, some of the biggest I've seen, and his PSA was about 14. We did an MRI that showed this massive prostate, no concern, and his PSA density was very low. So for him, a PSA of 14 is really not out of characteristic for a prostate that size. So again, I think you should be mindful of that slightly elevated PSA, but I think you'd have to do some other secondary testing to really get a better idea. Is that just PSA elevated for just a large prostate, or can there be something else be going on?
Okay. This question says, does testosterone treatment increase your risk of cancer?
No. And I want to be clear on this because this has been something that a lot of people have been worried about. That, hey, if I need testosterone replacement because my testosterone's low, and testosterone for an aging man is important, and not only for the muscle and bone, but there's evidence for the heart and brain. And so, by giving one testosterone for normalizing that testosterone to an appropriate level, it does not increase your risk for prostate cancer. There's actually been several studies now who men who have low grade prostate cancer, that Gleason 6 prostate cancer, that cancer that we're monitoring, who are on active hormone replacement. There's no risk in worsening their cancer. They did not see any aggression. Now, if one has an aggressive prostate cancer, they may want to hold that testosterone therapy until that cancer is treated. Because it's sort of throwing fuel on the fire, so holding it. But once that cancer is treated, depending on the treatment, that you could reinstitute that therapy at an appropriate time frame.
Okay. This question says, I was diagnosed with prostate cancer. I decided to go to the radiation treatment with hormonal therapy. The doctor mentioned that the radiation will be for 5.5 weeks, 5.5 weeks, and therapy for 6 months. The pills are expensive, and he said I have to do this for 6 months. Is this the cost for a 30-day supply or just a one-time cost?
Well, that's there are pills which we now usually prefer because it has a lower risk for heart side effects. It's cardioprotective, but sometimes they are they're very costly. And for patients where it's financially toxic, that's when you'd say, hey, this is not reasonable for me. And especially if you don't have any significant heart disease, then we can do a 3 or 6 month injection, which would suppress your testosterone for a low level. So I think that's a conversation you need to have with your radiation oncologist, especially if those medications, and they can be quite expensive. Now, if you're in the Medicare this next year, 2026, your out-of-pocket expense for brand name drugs will be $2,100. But still, that's real money. So I think that's a discussion you want to have with them. And don't be afraid to advocate for yourself. You don't want the treatment of a cancer to bankrupt the rest of your life. So you want to be thoughtful. And there are some very good alternatives that are not as costly, especially if there's no other significant cardiovascular risk. But the reason you do ADT or lower the testosterone, and I didn't bring this up, and I should have, but again, I didn't really want to focus too much on radiation because I really think that's best left for the radiation oncologist. That low testosterone, which is the primary food source for prostate cancer, it sort of weakens it. And then when you hit it with radiation, it makes that radiation a lot more successful at killing that cancer. So that's why it's usually recommended for 6 months for, I would assume you have a Gleason 7. And the higher grade cancers or more bulky cancers, sometimes we need to do it for 18 to 24 months because radiation doesn't just do it while you're having the treatment. It lasts, it denatures that tissue over the next 18 to 24 months. You're not radioactive, it's just slowly killing that cancer over 18 to 24 months.
Okay. This next question says, I'm 79 years old, and for a while now, I can't pee sitting down most of the time. Is that normal?
It is not uncommon at all, and frankly, a lot of people prefer it. I think sometimes it becomes a habit. I always tell people, I have two sons. I didn't tell them how to pee. I tell them when and where. Sometimes they still like to pee outside to water the tree. They'll hate me saying that. But we sort of develop habits. Sometimes it's just because it's more convenience, because maybe we share that with our spouse and we don't really want to lift up the seat or make a mess. So it's just easier to sit down. But I'd say as long as it's not a big bother to you, a lot of men, especially as they age, sit to pee.
Okay. Can testosterone therapy affect one's PSA?
It can acutely. So if you had a low testosterone and then you initiated therapy, you will see a acute rise in your PSA. But after about 3 to 6 months of maintaining that therapy, that PSA should drop down to a baseline level. So you could see an acute spike, but generally it will back down.
Okay. What would you recommend if your MRI indicated a 8 mm lesion and a PSA level of 4.1?
Again, when we look at those lesions, they give them something a PIRADS category. And this is an objective measure. They actually have AI technology doing this, but it's still preferred by radiologists. And data shows when radiologists and AI, they get a better result than AI. But if it's a PIRADS 3, and depending on where it is, because a PIRADS in the peripheral zone is not the same as a PIRADS in what we call the central zone or transition zone, then you may look at some other indicators, such as you may do one of those urine-based tests, or you may look at PSA density. If it is in the peripheral zone and it's concerning, then that small of a lesion, less than 10 millimeters, that's where I would lean towards a MRI fusion biopsy. It's a very big lesion, 2 or 3 centimeters. There's probably not much value in that fusion biopsy. But it really depends on the location in that PIRADS category.
Okay. This one says, if cancer has been found in the lymphovascular system in the prostate during a prostatectomy, does that increase the risk of cancer having spread outside the prostate?
It does. So when they look at the prostate in whole, they're going to look at certain things. They're going to look at what is the overall Gleason score, and they just give it one Gleason score. They look, does the cancer go outside the capsule of the prostate? Then they look at the margins. Does the cancer go to actually where we cut? Does it go up or go past it? And then finally, they look at the things inside the prostate, and there's really two things: nerves and lymphovascular or lymph and vascular vein vessels. Nerves perineural invasion doesn't carry too much risk. It just means that cancer's been there a while. It doesn't leave via the nervous system. But cancer cells leave through two of our circulatory systems: our blood vessels, that's our circulatory system, and then our lymphatic system. That's the other circulatory system that our white blood cells go through. That's what we have all throughout our body. And so when you do see lymphovascular invasion, that does increase your risks. What does that mean? Well, we're just going to monitor you a little tighter. Maybe instead of every 6 months, we might do every 3 months for 1 or 2 years. Because most cancers, if they're going to reoccur, most of them will reoccur within the first 2 years. So that is really the time you're going to be watching. But it is a lifelong surveillance that you need to monitor.
Okay. This one was just a clarification on the previous question. It says the question was, I can't pee sitting down most of the time anymore. Is that cause for concern?
That is that then that's where you're having a little difficulty initiating stream that and especially if it's become bothersome and maybe impacting your quality of life, or hey, I'm afraid to go to Home Depot because their bathrooms are in the back, but I love Lowe's because they have them right there. I only go to Target because their bathrooms are right at the front of the store versus going to HEB. They're always hidden in the back. If it starts impacting your daily routine or how you may do things, that's probably something you want to check out.
This one I might mispronounce this, but it says, can taking finasteride for hair growth affect PSA levels?
Absolutely. And that's something you need to really be cognizant of. So finasteride is a very old drug. I love it. It does a lot of good things for the prostate as far as shrinking it, helping men pee, and we've been using it. And it's also the drug you see on all the commercials right now for him and hers and every other commercial for that, because it does prevent hair loss. The dosage for the prostate to shrink a prostate is 5 milligrams. The dose for hair loss is 1 milligram. So we used to think 1 milligram probably does not impact the PSA, but I have seen it. So generally, if a person is on finasteride any dose, in my brain we double the PSA. So the calculation we have to make with finasteride, if a gentleman has a PSA of 3 and we put it on to shrink their prostate, we'll expect that PSA to drop to about 1.5. So when we get that PSA, we have to double it. So we change that to 3, and as long as it's stable. So if you do get a PSA and it's 4 on finasteride, you may want to either hold the finasteride for a few months, repeat it to get a real value, or you might, you double it to 8, you might want to see a urologist.
Okay. This person said that they were told that pumpkin seed oil is very helpful for prostate health and it shrinks it. Is that true?
I don't know if it shrinks it as much as it maybe helps with the inflammation that you see. So I think and again, the quality of the pumpkin seed, I don't think it's harmful, but I don't know, I don't see much impact in changing the architecture of the prostate. I typically don't recommend, I'm not a big supplement person personally, and I generally don't recommend them just for a routine prostate health. There are some situations with prostatitis, there are some supplements I like to help resolve the inflammation for those patients. But just as a spectrum, there's one I think really works, super beta prostate. That one I think I see a lot of good results from. So if someone wants to stay away from medicines, that's generally the one I recommend because it's easy to find and easy to get. But I'm sure there's a lot of other good supplements out there. I just don't want to, say that I'm a supplement expert on that.
Okay. This one says, I have interest in meeting with Dr. Messer. Does my urologist arrange this or do I go to the doctor directly? What is
You can just call our Apex Cancer Center and request a consultation with Dr. Messer. And you don't need a referral. Most of the time you don't need a referral depending on your insurance.
okay. And what is your opinion on the bar gel procedure?
Again, I didn't bring that up. I wanted to stay a little the barrigel procedure. So I talked about my grandfather's. One of them, unfortunately, did have a lot of radiation side effects to his rectum. And I first saw the makers of barrigel over a decade ago. It was a small Canadian company. And I saw it at a meeting and I said, "Oh, this is amazing. We need to get it." And he says, "Well, it's not approved." Then it got approved, and this was Spacor at the time, a different agent. And now pretty much everybody who undergoes radiation in our practice, if they're able to have a spacing agent, and there's two, there's Spacor, OAR, and then Barrigel. They're a little different, but at the end of the day, they pretty much do the same thing. They provide about a centimeter or 2 centimeters between the prostate and the rectum, and really take the rectal concerns out of the picture for most patients.
Okay. One second here. Okay, this one says, I saw your PA today and found out I have 3 + 4 = 7 adenocarcinoma on the right anterior peripheral zone. Aquablation was discussed. Your chart displayed a removal through ablation. I assume it is for a small one and not the whole prostate in your display.
Well, what I showed here was just some cartoons, I guess, of different ways of doing it. The treatment that he was referring to is that trial, the Water 4, that is removing the whole prostate. You would also, again, I'd have to look at the MRI, but you could do focal therapy with high intensity focused ultrasound if we only want to treat half the prostate. But we think we want to sort of introduce all potential treatment options. So I know Brian, who I'm blessed to be able to work with day in and day out, probably discussed that Water 4 trial. That's what it sounds like. And probably also talked about focal therapy as well.
Okay, and this one says radiation when the patient has ulcerative colitis. What are your thoughts?
Generally, the radiation oncologist, will probably try to avoid radiation in those individuals because it definitely can amplify one's ulcerative colitis. If radiation is really the only option, which generally it is not, they probably have you see a gastroenterologist for a colonoscopy and look at the rectum. But that is definitely a concern. And that's something that usually we try to avoid radiations in those unique cases. And again, that's a discussion with the radiation oncologist and the patient. And so I don't want to claim to be an expert in that situation. And so
Okay.
we're coming to, again, I would like to be respectful. We'll take one more question. We'll come to about 6:30.
Okay, 1 second. I think. Um, I think that is it.
All right. Well,
Awesome.
we'll try to get back to individuals with those questions, but I just thank everybody for tuning in. Hopefully you found this helpful. Hopefully you've seen, where I'm very passionate about this issue, and I really love being able to help individuals and their families go through this journey. And I'm really blessed to be able to work with some great partners here at Urology Austin. And I think Sarah and Jamie, thank you for helping put this together tonight. And I hope you guys all have a great night.
Yes, thank you so much for everyone participating. And thank you as well, Dr. Giesler, for sharing your expertise. For anyone that is interested, you can contact us to make an appointment at urologyaustin.com. And just one more plug here, because we have to, just to remind everybody to tune in tomorrow for the Dr. Drew Show featuring Dr. Giesler tomorrow at 7 a.m. Central Time on Lifetime Network. Thank you so much and have a great evening.